Ada.
Sorry lah, I lambat sikit. Sorry lah. Lambat banyak sebenarnya. Anyway, so let's start. You guys dah lama start dah kan? Dengar tak?
Dengar lah, tadi baru habis 9.30 hari.
Oh, lama dah habis. Okay, sorry lah. So, Alhamdulillah, Assalamualaikum warahmatullahi. Okay, so let's talk about nephrotic syndrome. So you guys nak fokus exam kan?
Betul.
Okay, so basically nephrotic syndrome is one of the station yang memang confirm akan keluar. Every exam dia akan keluar, okay, regardless. And usually dia akan either keluar, most of the time it will come out in your modified long case rather than in your OSCE. Except if we can get a patient who's currently in relapse, then we can include them in the OSCE lah. But usually modified long case definitely akan keluar. Okay, and most of the time the cases that we going to present to you are cases that are quite complicated. It's not a straightforward newly diagnosed nephrotic syndrome. The caveat is usually, okay, the aim of the station is for you to diagnose the complete diagnosis of the nephrotic, which mean whether this is the diagnosis that we expect from you should is either frequent relapse or steroid resistant, steroid dependent, okay, or infrequent relapse. And if you got the biopsy, then together with the biopsy results. So that is what we expected from you, okay? What we expect from you. So in your history, you have to ask all these questions. Okay, things that you need to ask in your history of nephrotic syndrome. Number one is when the diagnosis. Okay, you need to know when is the first diagnosis, at least the year of the diagnosis. And then how many relapse per year. Okay, sometimes the parents don't understand relapse. So how do you ask? Anyone? You want to ask the parents, how many relapse have your child had in the past 1 year? 1 year means, for example, if now is November, so from November last year until November this year, okay, until now, how many times they had relapse of nephrotic syndrome? So how do you ask that?
Urine dipstick. Ais regarding
Berapa
urine
kali
dipstick.
masuk hospital atau bengkak?
Actually kan, my patient, I don't admit them every time relapse. The only indication for admission in nephrotic syndrome is first, newly diagnosed. Okay, second is patient who has severe anasarca. Okay, severe means they've got either massive pleural effusion or affecting the respiratory system, or they've got gross anasarca affecting the genitals. Kan, yang tu baru you require admission. This is the patient that you need to give albumin. Okay, otherwise, actually you don't need to admit everyone with who is relapsed. Okay, so sometimes if you ask how many times they admitted, it may not be accurate. Maybe 1 time, but in fact relapse occurred like more than 4 times, for example. Lagi?
Urine dipstick.
Urine dipstick. What do you mean urine dipstick?
Ask parents about the urine dipstick reading took place for 3 days, consecutive 3 days.
Okay, that is also sometimes misleading because we've got a term what we call it breakthrough proteinuria. Even though breakthrough proteinuria usually less than 3 days, but it can occur more than 3 days. Okay, but it's still a breakthrough. So breakthrough is also not correct. Okay, because the definition of relapse, they must fulfill all the diagnosis criteria for nephrotic syndrome. Let's differentiate them with breakthrough, because breakthrough you got isolated proteinuria without the rest of the diagnostic criteria, without the albuminemia, the hypoalbuminemia, without the edema. What else? How else can you ask?
Bengkak or clinical edema.
Okay, bengkak is better.
Facial
Okay,
puffiness
bengkak is
ke?
better.
Oh,
Pardon? Apa dia?
sorry, facial puffiness.
Okay. Problem dengan bengkak kan, facial puffiness sometimes is a bit problematic because if patient only on hydrosteroid for long time, so they can develop in like apa Cushingoid kan. So sometimes they confuse Cushingoid dengan facial edema. Edema also has a problem because for example in patient with steroid resistant or patient with steroid resistant where they don't achieve remission after quite some times, for example like 2 months without remission. So sometimes parents confuse, oh, and then today looks better and then tomorrow looks worsening edema, but they still got edema but it's worsened. So sometimes they thought it's a two different relapse, but it's actually not. It's only one episode of relapse. Faham kan? So
Faham.
sometimes the edema is also quite tricky for parents to answer. Okay, actually the best way is how many times you can ask how many times did the doctor prescribe you. First you can ask, okay, how much is what is the highest dose of prednisolone you receive? How many tablets? Contoh dia kata, oh at diagnosis doktor bagi 10 tablets, okay, or 8 tablets or 12 tablets kan. Then you ask how many times in this year from last November until now that the doctor started you on 12 tablets.
Just tablet apa?
Okay, which means we induce. Or you can ask how many times you have to be induced this year. Kalau parents yang educated dia faham lah, tapi most parents they don't understand. So tanya dia berapa kali yang doktor bagi 12 tablets yang you kena ambil. Yang doktor start 12 tablets. So that's induction. So that is the most, I think that's the best way lah for you to ask. Okay. But for educated parents atau patient yang dah long term prolonged nephrotic syndrome, they can actually understand lah. You boleh tanya berapa kali relapse, then they can simply tell you. Because this will help you with the diagnosis. Kalau if you didn't get the right diagnosis, then you won't get marks for diagnosis in nephrotic syndrome. Because we be very detailed and very good in nephrotic syndrome. So for example, if you just answer nephrotic syndrome, we don't accept that. So we want a complete diagnosis, frequent or infrequent relapse, or steroid resistant or steroid dependent. Okay. Macam mana nak tahu dia steroid resistant atau tak?
Biopsy have been done.
Pardon? Require biopsy?
No, the symptom doesn't resolve after 2 weeks. After 1 month of treatment with steroid.
Okay. Actually in clinical setting, we do allow up to 6 weeks. Memang buku kata for 4 weeks. Definitely book said is 4 weeks. But usually, okay, we know some people they are quite they've got what you call it delay response. So we do allow up to 6 weeks. So you can ask that. Okay. Another way is kalau steroid resistant.
You ask the mother if they change medication to cycle.
Okay, very good. Okay, if they require change of medication. Okay, kalau because steroid resistant, they should not be on steroid. They should not, because we will stop the steroid in steroid resistant. But if the mother said, "Oh, doctor, add medication," that doesn't mean it's steroid resistant. If add medication, it can be steroid dependent. We just want to reduce the dependency on steroid. But if they change the medication, it's usually steroid resistance. But remember, we won't start any other steroid sparing agent without biopsy. Okay, usually we will do biopsy before start new agent. Okay. So usually kalau patient had biopsy done, it's almost always steroid resistance. But remember one more thing is, phenotype can change. Okay, sometimes maybe at the beginning they are steroid resistant, but later on they can change to steroid dependent or change to steroid sensitive. Okay, so it changed. So you need to ask the mother carefully. For example, mother said in the past, patient respond to prednisolone, but now no longer respond. So you can shift lah from steroid resistant, steroid sensitive to steroid resistance. Okay, apa lagi so if you can relapse, you tahu kan, it has to be more than 4 times per year or more than twice in 6 months after diagnosis. So if patient is newly diagnosed and the first 6 months of diagnosis already had more than twice, this is also called frequent relapse. Another way, how about steroid dependent? How to tell that patient is steroid dependent?
When the symptom recur after tapping down or stop of the steroid.
Okay. Again, how to tell that symptoms occur after tapering down?
Or maybe you can ask the mother if it's more than 10 or 12 tablets being prescribed by the doctor.
Okay.
Ask the
Because more
mother,
than 10.
ask the mother, because usually when after 2 weeks we will reduce the dose 2 weeks kan. So ask the mother, lepas doktor suruh stop the medication, lepas doktor suruh stop the makan tablet tu, within 2 weeks symptom tu jadi ke tak? Jadi balik ke tak?
Okay, that's another way. But you have to remember, steroid dependent doesn't mean they need the steroid, the lowest dose steroid. Sometimes it can be they need higher dose steroid. So depending, for example, you induce the child and then you taper to EOD dosing. For example, they require like 20 mg EOD dosing. And then when it goes down to 15 mg, they relapse or they've got breakthrough proteinuria or they relapse. Then it means that they are also considered steroid dependent. They cannot taper down. It's not necessarily cannot off. Cannot taper down is also steroid dependent. In fact, those yang cannot taper down is more dangerous than cannot off. Okay, because usually those who cannot taper down steroid, they usually will end up become steroid resistance. Okay, faham kan? Understand kan?
I have a question, Dr. Alwi. In patient who has a relapse, do we go back to 4 weeks of prednisolone again?
Pada?
So if a patient relapsed, for example, when tapering down, after the 4 weeks of 60 mg prednisolone, for example, we taper down. Patient, while tapering down, maybe in the 3rd month after the prednisolone first month, he relapsed, he or she relapsed. Do we go back to our initial episode of prednisolone again, 40 mg for 4 weeks?
Okay, if patient relapse, which means the full-blown relapse can fulfill the criteria of relapse, then you need to reinduce. But if patient develop breakthrough proteinuria, for example, already negative proteinuria, no proteinuria, and then when they taper down, it increased. They got like 2-3 plus again, then you may need to increase back to the previous dose. And usually, we will increase back to the previous dose and then give them and ask them to take daily dose of the previous dose for at least a week. Then only they continue with EOD dosing. We have to treat them like breakthrough proteinuria. Understand, right? It's not necessary for you to actually induce them again during the period of tapering, but sometimes it's just enough for you to just increase the frequency from EOD to OD, and also to goes back to increase back the dose to the lowest dose possible that can maintain the remission. Okay, that's one thing. Okay, Number two is that's all about the diagnosis. Number two is when you clocking a patient with nephrotic syndrome, you have to understand this is a chronic disease. Okay, when this is a chronic disease, you have to before you go further, okay, you have to find the main objective of your clocking. Number one is to determine the phenotype of the nephrotic syndrome.
Phenotype.
Number two is to determine the triggers for relapse.
Huh?
Why patient relapse this time? If patient presented with relapse, why relapse? Is it because non-compliant to medication, or is it because of infection, or is it just simply progression of disease? So in your history, you should ask questions. For example, like, is there any fever, any infection, UTI, or any UTI symptoms? Or sometimes any recent vaccination. Vaccination can actually triggers relapse in nephrotic syndrome. Anything that can boost your what you call it, your immune system can actually trigger relapse in nephrotic syndrome. Okay. So what else? Lagi ya. So how do you manage nephrotic syndrome? Haris Syahmi lah, Haris Syahmi. Asyik Murad dengan Sambar je.
Asyik aku.
So Haris Syahmi, Ashmat. So if in modified long case, you have to explain how you manage, okay? So how do you manage?
First, we need to assess the hypothermic status of the patient. Whether the patient is hypovolemic or hypervolemic.
Okay, good. So if hypovolemic,
we do not don't give the patients full diuretic, even though patient with edema. Do not give it.
okay, so what you give?
Hypovolemic,
So
we
what-
give
So what do you give?
Albumin.
Patient are hypovolemic. So what do you give?
we need to give albumin.
Albumin. How many percent albumin? You have to be specific tau. You don't give albumin
Okay.
per se.
2 gram,
Berapa persen? Berapa?
20%.
20%. Yeah, 20%. How do you manage patient with hypovolemia? In general, how do you manage patient with hypovolemia?
We resuscitate. We give normal
Bagi what?
Hypo yang tak boleh.
saline.
You buy crystalloid kan?
Yes.
Okay.
Normal saline.
So you buy crystalloid lah. You buy normal saline ke, self-funding ke, but crystalloid lah. Isotonic solution. Okay. So same goes with patient with nephrotic syndrome. If hypovolemic, you give fluid. Okay. However, we know that this patient, they cannot retain the fluid because low oncotic pressure. So you have to give colloid rather than crystalloid. Okay. So what type of colloid you can give is albumin 5%. Okay. You don't give 20% albumin for resuscitation. Okay. You will kill the patient. Okay. You give 5% albumin for resuscitation. Ataupun 5% albumin is a type of colloid lah. So give 5% albumin for resuscitation or for replacement of fluid replacement in patient with nephrotic syndrome. Remember, it's 5% now, bukan 20%. 20% is only to replace albumin. Okay, for example, patient with gross anasarca, then you give 20% albumin to replace albumin. Okay, understand? Okay, what else? How do you manage again? Lagi?
Then we need to start.
Asal ada KFC bucket.
Nur Syamimi Amalia.
Library.
What else? Remember, when management is asked, you always start with A, B, C, D. Okay, always start with A, B, C, D. I will assess A, B, C, D. Airway, breathing, circulation, and then disability. Then include in the circulation is the hydration status. Kan? Then you manage based on hydration. Okay, pasal apa lagi? Apa lagi Syamimi? How do you manage?
Start breathing hold kan?
For general management, in terms of diets, I would allow a normal protein diet.
Okay.
But if patient have macam terus edema, maybe
Maybe what?
Sebut.
Show me, okay.
Pernah dia putus juga.
Okay. Okay nak.
Hello, Doktor. Sorry, the internet saya putus.
Okay, so okay. So be careful like in patient with relapse kan. When you see someone with edema, they also got edema elsewhere. It's not only under the skin tau. The bowel will also have edema. Okay. So usually we don't encourage give complex or high protein diet in patient with relapse. That's why if you want to replace, then you have to replace with 10%, 20% albumin. Okay. So management you can divide into conservative management or active management, or medical management or non-medical management. So, but part of management is diagnosing. Okay, investigation is also part of management. So you always start your management with ABCD, and then based on your assessment, ABCD assessment, you will manage accordingly. If patient got airway problem, which is quite rare lah for nephrotic syndrome, got airway problems, then you will manage. Maybe require intubation. If got breathing problem, for example, tachypnea because of possible ada pleural effusion, then you may need to give oxygen or ada NIV ke or intubation if needed. Okay, and then thirdly, circulation, hydration. So you manage hydration. So if patient dehydrated, then you give albumin 5%. If patient shocked, then you resuscitate. Okay, and then you investigate. Okay, I will confirm the diagnosis of relapse ataupun diagnosis of nephrotic syndrome by sending investigations such as 24-hour urine protein, urine PCI, and so on lah. Okay, once confirmed diagnosis, we will start the patient with induction, steroid induction. Then you can mention the dose. We expect you to know the dose. It's 60 mg per meter square per day. Okay, that's the maximum dose of 60 mg. Okay, and then cakap lah for how many days for newly diagnosed, it has to be 28 days regardless. Patient dah 3 days negative, you have to complete 28 days for newly diagnosed. But for just relapse, once they achieve remission more than 3 days, you just stop. You just taper down straight. Okay. Lepas tu apa? Lepas tu apa lagi?
Saya nak tanya.
Ha.
Tadi one of the management is investigation to confirm diagnosis kan? In case of relapse, kita kalau buat urine dipstick yang 2+ saja boleh tak?
Tak boleh. How do you diagnose relapse? Okay, diagnosis of relapse, they must fulfill all the diagnostic criteria of nephrotic syndrome. So what are the diagnostic criteria of nephrotic syndrome?
Still fulfill semua. Saya ingat kan salah satu je ada cukup. Kalau relapse, tak?
No, tak. Dia mesti kena fulfill. That's why breakthrough proteinuria, dia mesti ada edema tau. In relapse, okay, ideally you need all. But in clinical setting, we just need number 1 edema and urine protein diagnosis of urine protein lah. Ada proteinuria in clinical, but actually the diagnosis of relapse is similar to diagnosis of newly diagnosed nephrotic syndrome. Cuma in clinical kita tak hantar lah balik PCI. We don't send back PCI. We won't take the cholesterol level because once they got edema, then we know lah. Because it's quite rare lah for someone with nephrotic syndrome and then develop liver failure. It's quite rare. Or suddenly develop heart failure leading to edema. So usually got edema, confirm with urine protein, then we can say this is relapse. Okay, faham?
Faham.
But actually when diagnosing, you have to fulfill all the diagnostic criteria. Mesti ada edema, mesti ada proteinuria. Proteinuria more than berapa? Over 24 hours. More than?
1 gram.
40.
More than 1 gram kan? Lagi? Hourly?
Hourly 14
40 kan? 40 per hour.
gram.
40 mg per hour. Lepas tu kalau urine PCI?
200 milli.
Okay, very good. Okay, lepas tu apa lagi?
Lipidemia.
Okay, apa lagi? What else is the treatment? And then based on your assessment, you have to assess whether this is overfill or underfill. Kan? Okay, kalau patient ni underfill, how do you tell patient is underfill?
Patient hypovolemic.
Signs of dehydration, patient have abdominal pain and low BP.
Okay, so you assess by the degree of hydration kan? Hydration status and then any sign of fluid overload. I mean nampak dia macam overload lah. Okay, so if underfill, how do you manage?
Tadi IV fluid.
Can we start with resus colloid like albumin 5% and
And then you don't give furosemide kan? Tapi kalau dia overfill, then you can actually give furosemide alone without albumin. Ataupun you give, but usually we give albumin with furosemide. Because in patient with nephrotic kan, if you got low albumin, furosemide will not be effective. Because furosemide dia bound to albumin. Without albumin, furosemide cannot get into the target ni lah, site of action, which is you punya ni lah, loop of Henle. Okay, ada lagi soalan? Buat asal nephrotic tu je kot.
Betul.
Lagi soalan.
Fluid restriction, dia kita akan advise upon discharge ke waktu di maintenance?
No, you don't give fluid restriction kat patient nephrotic. You will kill them. No fluid resection in patient nephrotic. No fluid resection. No sodium restriction. They don't have any restriction. You cannot ask them to stay still. They kena walk around. They kena always active. That's why you bagi albumin in patient with scrotal edema or vagina labial edema, because you want them to be active. Because by being active, you will increase venous return and you will promote diuresis. So you will lose the water more. Better, faham tak? So you remember, you don't mix up nephrotic and nephritic. This is what happened to most students. Because the pathophysiology is totally different. Management is totally different. Treatment is totally different. Clinical is totally different. If you treat nephrotic like nephritic, you kill patient. If you treat nephritic like nephrotic, you kill patient as well. You have to be certain this is nephrotic or nephritic. There are some gray area where patient presented with nephritic with nephrotic range proteinuria. However, management is always following the main pathology, which is nephritic syndrome. So, remember, okay, so kalau nephrotic, what is the problem? What is the pathophysiology of nephrotic?
Loss of protein.
Right.
Effacement of the podocyte.
So apa jadi bila efface?
Loss of protein.
Loss of
Loss of
protein.
protein kan? Bila loss of protein, you reduce oncotic pressure. Bila reduce oncotic pressure, jadi apa? Third space loss kan? So you ada third space loss water. So reduce intravascular volume. So treatment dia ialah you replace albumin to increase oncotic pressure. Therefore, it will retain fluid in the intravascular. So that's nephrotic. So apa jadi? Dia akan lost third space kan? Where is your third space? You ada pleural space. You ada peritoneal space kan? So these are area yang fluid akan accumulate. So you end up dapat pleural effusion. You end up dapat peritonitis. Ni lah dapat ascites. Okay. Okay. So these are the pathophysiology of nephrotic. But in nephritic is other way around. The other way around. So nephritic apa yang problem? Where is the site of lesion?
Glomerular, usually inflamed.
Glomerular. So what happened?
So when it's inflamed, basically it has endothelial injury and hence causing the mild proteinuria and also edema. But most importantly is the hematuria.
The what?
Hematuria.
Okay. So what happened? What is actually the problem?
Inflammation of the glomerulus.
Okay. So what does it cause? Glomerulus is for ultrafiltration kan? It'll filtrate. So when there's inflammation, okay, well, actually it's a type what of hypersensitivity reaction? AGN is a type what of what type of hypersensitivity reaction? It's type 3 kan? It's complement kan? It's a type 3. Nephrotic syndrome is type 3. Okay, it's complement deposit. So complement deposit at the glomerular, at the GBM. So what happen is it reduce ultrafiltration, so leading to fluid overload. Right, so they got oliguria, so fluid overload. So what happen is when there's too much fluid, so the fluid overload to the lung, overload to everywhere, causing edema. Okay, it's not interstitial edema tau, it's intravascular edema. Because there's too much blood in the intravascular, so it's causing lymphatic clogging the lymphatic, so it causes edema. Okay, on top of that, it causes pleural edema. It causes pulmonary edema. It doesn't cause pleural effusion. It causes pleural edema, pulmonary edema. And then because too high, there's too much volume, so it causes hypertension. And hypertension causes hypertensive crisis and organ damage. So they can end up with seizure. Okay, faham kan? So what is your expected findings in nephrotic syndrome? When you do PE, what is your expected findings?
Nephrotic.
Afiq Shahrin.
Nephrotic lah betul. Sekejap dah kata kalau nephritic tadi.
Yes, betul. For nephritic or nephrotic?
For nephrotic.
Kompleks dalam ni.
Nephrotic.
Glomerular filtration system.
So for nephrotic,
So
first we can see if there is any ascites.
Okay.
Nephritic.
And then
lung.
And then we kalau lung ada if ada effusion, pericardial effusion.
Pericardial effusion. Pericardial. Pleural effusion.
Pleural effusion.
Okay, nephrotic syndrome dari pleural effusion. So bila you pekas dia apa?
Dia ada dullness.
Is it dullness?
Stony dullness.
It's stony dullness. I remember it's stony dullness. Pleural effusion mesti stony dullness, reduce breath sound. Kalau pulmonary edema, they got dullness plus cramps. Understand?
Yes.
So don't mix up, okay? In nephritic syndrome, they've got cramps, especially bivascular cramps, gravity dependent, with dullness, okay? And bronchial breath sound. At the level or at the fluid level, dia akan dengar bronchial breath. Sometimes, dia tak ada bronchial breath sound. Sorry, dia tak ada bronchial breath sound. But in nephrotic, you've got pleural effusion, reduced breath sound, no cramps, and you got stony dullness, okay? Sometimes you can get cramps lah in nephrotic if the pneumonia triggers the nephrotic relapse. Okay, ada soalan? I think that's all kot.
Tanya.
The rest saya rasa boleh baca lah buat nephrotic. Nephrotic you need to read. You need to read and understand. Make sure you understand the difference between each phenotype, and then when biopsy is needed, And most of the time, you have to understand nephrotic syndrome is a dynamic disease. It's a progressive disease, okay? Some people end up cure, but about 1% of the patient, they end up end stage. So, you have to determine this. For example, if you come across a patient and then you clock, and then you have to understand if from your history, if you think the child has steroid resistant, and then the disease like progressing, then you have to anticipate whether is the child is actually CKD now, or the child is actually still normal kidney function, normal GFR, but just poor nephrotic control. Okay, faham tak? Because at one point, this steroid resistant nephrotic syndrome, they will end up become CKD and ESRF. Okay,
Tengok DFR.
faham tak?
Faham? Okay, tu.
Okay, ada soalan tak?
Doctor, I have a question. Just want to clarify on the overfill just now for nephrotic. We will give albumin first and then furosemide, right?
Okay, you will give. Okay, hold on. Sekejap.
Gambar kau. Apa nak tengok gambar kau?
Okay, okay, in overfill, you have to remember, Lasix, you give infusion. Albumin, you give infusion. Okay, albumin, you give infusion usually over 4 hours. You don't give bolus. So, the Lasix is given in between. So, after 2 hours in between the infusion lah, you give Lasix. Okay.
All right. Thank you, doctor.
Okay. Anything else? Acetoskop nephrotic.
Kita nak tanya kalau nephrotic kan dia datang dia ada pleural effusion tapi nephritis pulmonary edema.
Ya.
Macam boleh ke patient tu nephrotic tapi dia ada acute pulmonary edema?
Okay, if they are overfill, they can. Literally they can, but it's not typical lah. It's not typical. Okay, it's very rare. Even those yang overfill, even though those nephrotic with overfill pun, they rarely get pulmonary edema. And in fact, it's very difficult for you to hear claps tau, to diagnose to diagnose pulmonary edema in a patient with overfill, because they will get pleural effusion first, then only they get pulmonary edema. So the pleural effusion will reduce the breath sound, so you won't hear the claps. You can lah, theoretically you can, but in real life you won't hear the claps because they've got the pleural effusion that dampen the sound, that reduce the breath sound. Faham tak? So you don't get so in general you don't say patient with nephrotic syndrome have craps. If they got craps, it has to be pneumonia. Okay. And also you have to remember, pulmonary edema, the collapse is a fine collapse. It's not cause collapse macam pneumonia.
Semua tepat-tepat.
By listening to the collapse, you can tell this is a fine collapse or this is a cause collapse. Pneumonia, they have cause collapse consolidation, but in pulmonary edema, they've got very fine collapse. It's a, because it's not consolidation, it's a collapse. Due to, I mean, when the lung is inflated and deflated, they can get collapse. But it's not like consolidation, so it's very soft, very fine. Okay.
Okay, Doctor, thank you.
But in general, if you confirm this is nephrotic syndrome, you hear collapse, you don't say this is pulmonary edema, you say possible this is infection, pneumonia. Because you have to understand juga, the nephrotic syndrome, they've got reduced immunity, kan? They lost the immunoglobulin from the urine. So they are prone to infection. They're prone to get infection. So they can get pneumonia. On top of that, they are on hydrosteroid. So they are quite immunosuppressed. Oleh satu, you have to read on the side effect, the complication of nephrotic. So when you clock a nephrotic case, you have to ask the presence of any of these symptoms of complication, such as cavernous sinus thrombosis. So ask them, does they have any headaches or seizure or altered mental status, altered behavior? And then does they have any hematuria or loin pain because of renal vein thrombosis? Any calf pain, DVT? What else? Any diarrhea, vomiting, fever, SBP, spontaneous bacterial peritonitis? Itulah kot. Okay.
Doktor nak tanya.
Tanya.
Doktor, saya nak tanya untuk indication untuk penicillin V. Kita bagi kat semua yang patient yang growth edema je ke ataupun patient lain kita bagi?
Penicillin V.
Lepas tu
penicillin V.
Untuk prophylaxis SBP. So nak tanya kita bagi kat patient yang growth edema je ke atau patient yang macam resistant kita bagi juga ke?
Actually kan, the penicillin V bukan untuk SBP prophylaxis. In fact, SBP, you don't manage SBP guna penicillin. SBP, spontaneous bacterial peritonitis, you manage guna broad spectrum third generation cephalosporin. Usually we add flagyl lah, you cover for anaerobes. Cuma the penicillin is not is actually to prevent further infection. You have to understand, nephrotic syndrome is immunological disease tau. It's not kidney problem. It's actually immunological reaction. It's sort of like autoimmune. Okay, it's an autoimmune lah in a way. So you give when it's usually triggered by infection. And the most common community acquired is a gram-positive infection. So penicillin group is the best. So that's why you give penicillin, and the dose is different than the post-steroid AGN. Berapa dose penicillin in nephrotic syndrome?
125 mg BD.
BD kan? It's not QID dosing. Because it's just you want to prevent further infection. Because if they got infection, they can it can actually trigger the immune response, so it can worsen or delay the remission. So but it's not for SBP prophylaxis. So you give everyone newly diagnosed. For newly diagnosed, you give penicillin, but it's not really for prophylaxis SBP lah actually.
Faham? Lepas tu doktor, untuk kita buat renal ultrasound ke doktor sebelum buat renal biopsy?
No, you don't do renal ultrasound. Except if you're not sure whether, usually if the creatinine high, then maybe you do renal ultrasound. If not, you don't do renal ultrasound, because you have to understand the biopsy is ultrasound guided. So you doing ultrasound together with biopsy. Faham tak?
Faham. Kira creatinine
you
high
don't
tu
need
sebab
to
kita
atas.
ada CKD ya doktor. Takut dia shrink.
Yes, kalau patient dah CKD, no point buat ni. No point for you to do biopsy. You don't do biopsy on patient with CKD because you won't get anything. You will get fibrous tissue. That's why biopsy is only done in patient yang tak end stage or tak CKD. Okay, ada lagi?
Doctor, I have a question. When do we discharge this patient?
Okay, when you think the child okay, you discharge lah. For newly diagnosed, you only discharge after 3 days of 3 days of negative proteinuria for newly diagnosed. But for those who established diagnosis, came for relapse, doesn't matter. Like I've mentioned, you don't need to admit pun. So if you admit and then they're okay, for example, the reason for admission, for example, you admit because gross NSLK, then you give albumin. Once the NSLK resolve, you discharge lah. You don't wait until negative. I don't admit lah my nephrotic syndrome. Unless kalau ada crisis. Okay, how do you differentiate steroid side effect and steroid toxicity? Ini you kena baca. What is example of steroid side effect? Side effect is something that you expect to happen to everyone. Okay. Yes, cushingoid features is side effect. Kan, in fact, you use, kalau contoh you bagi steroid and then patient has no cushingoid features, then you know the patient is not compliant to your treatment. Okay, so that is a side effect that you expect. For example, what else? Emotional imbalance. These are also side effect. But undesired effect that is not expected to happen. For example, myopathy. Patient become proximal myopathy, become weak. Or growth retardation. Or glaucoma, cataract, or osteoporosis, rickets. These are the things because it's affect vitamin D punya metabolism. So these are actually toxicity. Any sign of toxicity, you can off. You can off steroid. Okay, ada lagi?
Doktor, patient nephrotic syndrome ni kita parents memang akan buat dipstick hari-hari and sampai bila?
Sampai dia discharge.
Sampai dia discharge. Kalau kat rumah kan sebab macam dah tahu dia jumpa dekat kes dekat apa Temerloh dulu. Hari-hari dia buat even kat rumah, so sampai bila sebenarnya?
Sampai kita kata stop lah. Sampai dia discharge. Sampai sampai dia cure.
Oh.
Sampai
so daripada situ lah breakthrough ke tak?
That's why lah.
Breakthrough.
Kita kena tangkap all the breakthrough lah. We want them to detect the breakthrough atau relapse. If they don't do, then they miss the breakthrough lah. If you don't treat the breakthrough, they can up to full-blown relapse. We want to catch them during the breakthrough period, breakthrough proteinuria, to prevent relapse. Faham tak? Okay.
Doktor nak confirm balik yang soalan tadi. Kira kalau macam special on tempering down tu kita memang kena check dia punya lipstick lagi lah sampai dia stop.
Sampai dia discharge. Sampai years. Usually we only discharge after patient not on treatment, no longer on any treatment for a year. Or more lah, biasa at least a year. For example, patient dah tak relapse for at least a year without any steroid, then we can think of possible discharge. But usually 2 years or 3 years without relapse baru kita discharge. Biasa after a year without relapse, then kita akan beri TCA 6 monthly or yearly. Dan kalau tak ada juga, then discharge. Then only they can stop checking the urine. Itu pun some people they do come back after 2-3 years of relapse. 2-3 years of remission, they can actually come back. Okay. Okay tak? Okay, one last question. Kalau ada.
Ada tips.
Doktor, untuk steroid resistant, kita
Hmm.
induce dengan agent dia lah.
Macam ni? Kita induce what?
Kalau steroid resistant, kalau dia relax, kita kena induce dengan apa?
Cyclophosphamide kan?
Okay, kalau steroid resistant, kita akan induce dengan dia punya tu lah. Dia punya steroid sparring agent dia.
Cyclophosphamide.
Usually kita akan start dia punya, if they relapse, okay macam ni. Kalau patient yang steroid resistant, okay, sometimes we can try bagi steroid. For example, patient dah on cyclosporine and then maintain remission on cyclosporine. Okay, and then suddenly they relapse. Sometimes we can try bagi steroid, look at the response. If patient respond, because like I've mentioned, the phenotype ni dia changes. So sometimes after you started steroid sparing, it change the phenotype to steroid dependent. So if steroid dependent, then you boleh bagi prednisolone. Faham tak? Only steroid resistant je you tak bagi steroid. Steroid dependent, you still induce dengan steroid. Because it's the safest, cheapest agent. Faham tak? So in treatment of relapse is the same. Except for steroid resistance, usually we induce balik dengan dia punya itulah we just increase the dose of dia punya steroid sparing agent. However, kalau dah after sometimes dia dah tak pernah lama tak relapse and suddenly dia relapse, then kita boleh start balik dengan steroid. But at the end yang tu you won't be asked lah that questions because that is nephrologist punya management. Because patient on steroid sparing agent should have nephrologist punya TCA. Okay. Okay lah, I've got student lah. I've got my master student. Kena attend tu. Okay, ada soalan last? Kau tak ada? Okay kot. Ada satu last. Kau tak ada dah.
Doktor, soalan ni bukan nephrotic lah, boleh tak?
Apa dia?
Kalau in heart failure, dia pulmonary edema or pleural effusion, dan saya macam mix up sikit dia punya pathophysiology.
Okay, you kena tahu dia punya stages kan? Kan kalau you tengok X-ray, orang yang ada pulmonary edema, what is the stages? Dia ada 4 stage. Okay, the last stage dia akan ada pleural effusion. Pleural effusion is the last results. Same goes with pulmonary edema because of nephrotic syndrome ke. The last results will have pleural effusion. They will have pulmonary edema because in heart failure, the problem is there's normal oncotic pressure, so they have high intravascular volume. Intravascular tau, dalam blood vessel. So this will cause edema of the lung. Tapi dia takkan seep out through the third space. However, if this persists, okay, and then dia akan overflow to your lymphatic drainage, causing edema, and it persists lagi, lymphatic tak boleh cope, dia boleh seep out to third space. That's why in pulmonary edema kan, in overload, okay, even though they can have edema, but usually it's non-gravity dependent. It's not really pitting as much as in nephrotic or in liver failure. Because in nephrotic, it's a third space loss. In nephritic atau heart failure, it's not third space loss. So they've got edema bila dah teruk sangat. That's why kalau you tengok kan X-ray heart failure kan, nampak ada curly B line and then upper lobe diversion semua tu kan. Last kali kalau ada pleural effusion, then dia stage 4. Sekejap lah, ada
Stage of cardiac failure. Tak tahu pula dia stage. NYHA tahu lah tapi Kan ni game yang aku main kan. Game yang aku main. Tiap hari ambil duit. Buat askar baru.
Okay lah, ada lagi tak? Kau, kalau tak ada, I rasa WhatsApp lah, because my student tu dah bising.
Thank you, Doktor.
Okay?
Okay, Doktor.
Okay, no hal.
Thank you,
All the best.
Doktor.
Make sure don't mix up nephrotic and everything. Okay?
Thank you, Doktor. Kalau sama bocor.
Doktor.